right, everyone, welcome to another Roast Rounds for today. We have a special guest once again, and so I'll let him take over.
Hey everyone, this is Samir, pathology resident, back again. Just when you thought it was safe to come back to Roast Rounds, here I am. So today we have two interesting specimens that are closely related to each other. So I guess without further ado, I will put the first one up. Hope everyone feels welcome. And so given that we've had a few of these specimens recently of a similar nature, I'm wondering if anyone in the chat maybe wants to comment on, first of all, what they think this surgery is as I display the specimen. Okay, so we have a hemicolectomy, a thought there, okay. Could it maybe be more than that? Another person says total. Yeah, so this one could be close to a total colectomy. And so if we were just to review our anatomy here, this is our proximal end, our cecum. On the flip side, to prove it, we have the appendix over here. We then have our ascending colon. We have our omentum hanging off as a good anatomical landmark of transverse colon. And then we get into our descending and possibly sigmoid colon. So this is close to a total colectomy. It might be a subtotal colectomy, but typically a hemicolectomy would probably end somewhere around here. So it's a bit more than that. Yeah, we have two more subtotal colectomies. So yeah, so that's probably the most correct in terms of the specimen type. And now there's obviously something going on with this specimen. Does anyone want to comment on what they think is the abnormality? Okay, so we have one person who said FAP, so that's certainly a good thought. So for everyone, FAP is familial adenomatous polyposis, which is a syndrome resulting in numerous colonic polyps. And so if we look here, we do have something going on in the colonic mucosa. It looks very ragged and sort of darker than usual and quite bumpy. One thing to keep in mind though is in the involved area, basically the entire mucosa seems to be involved rather than what we'd expect in FAP, which is numerous small polyps, but the background should be relatively normal and it shouldn't be this diffuse sort of dark coloration. The other argument against FAP is we have a very sharp transition point right here at the cecum on one end and the ascending colon on the other end. And so it'd be odd for the cecum to be so spared if this was FAP. We have a few other thoughts here that say ulcerative colitis, so that's good. So that's the history we've been given for this specimen. So this is a very nice example of ulcerative colitis. We have sort of diffuse involvement starting distally and moving proximally with a very abrupt transition at the cecum. And so certainly you can get this sort of polypoid appearance in areas. These are probably going to be inflammatory type polyps or pseudopolyps if we were to look at them under the microscope. And so one important thing just to keep in mind whenever we have a colon, be it for UC or otherwise, is just to refresh ourselves on the anatomy of the colon and what's retroperitoneal and what's intraperitoneal. And so I think that's the subject of our first poll question today. So our first question is, which of the following parts of the large bowel is retroperitoneal? Appendix, cecum, transverse, descending, or sigmoid? Okay, perfect. So the majority got the correct answer, which is descending colon. And so the other parts indicated they're all intraperitoneal. And really that's most important when we're thinking of the situation of a malignancy, because whether a segment of bowel is retroperitoneal or intraperitoneal is going to dictate what our radial margin is going to look like. And so if we have a segment of bowel that's retroperitoneal, like the descending, we're going to have a true sort of radial margin where in the retroperitoneal aspect where that part of bowel has been dissected off. And so I think we have a bit of it represented here. And actually, if you look at the specimen, it's quite smooth over here, which is probably more of the transverse, which is intraperitoneal, but then we have a more roughened area here, which is probably a true margin where the descending is maybe starting in this particular specimen. And so remember, if you're dealing with an intraperitoneal portion of bowel, you don't really have a true radial margin, and rather you would have a mesenteric margin where the mesentery has been cut. as opposed to when you have a retroperitoneal segment. And so just to review how one would approach one of these specimens in terms of grossing it, as per usual, we'd be interested in taking our proximal and distal margins en face. In this case, we don't have a history of a malignancy. We're going to limit our sections to about 1 per every 10 centimeters in the uninvolved area of bowel, and then 1 per 5 centimeters throughout the rest of the involved areas of bowel. And of course, we're going to look carefully at our fat as well to make sure there's no nodular areas or suspicious lymph nodes, and we'll submit 1 or 2 blocks of representative lymph nodes, assuming there's nothing abnormal, just to document that. And of course, we want to, before we gross any specimen, go back to the history and any previous biopsies to make sure there's no previous history of dysplasia. And if there is, we're going to sample more thoroughly in that particular area. And so we're submitting sections and we're going to examine them histologically. And given that on the gross appearance, we're really thinking this is going to be UC, when we look at the sections under the microscope, we're going to see features of chronic colitis, presumably. And so our next poll question is on that theme of microscopic features in a chronic colitis. So our question is, which of the following microscopic findings in the rectal mucosa, so distally, would suggest a chronic colitis? Is it a Kolschitsky cell, Paneth cell, mucophage, plasma cell, or enterocyte? Okay, perfect. So Paneth cell. So majority got the correct answer here. Does anyone in the chat maybe want to comment on what a Paneth cell is or what its role is in the colon? So Paneth cells are cells found in large numbers in the small bowel and a few sort of in the more proximal part of the large bowel. They're under the microscope, they have these large red granules, and they're primarily used for defense, host defense against microbial organisms. And so the whole trick with that is if you see them in the proximal area of the colon, that's kind of normal. But if you see them distally, like in the rectum, that's an abnormal histologic finding there. For the other ones, does anyone know what a Kolschitsky cell is or another name for that? EC cell, perfect. So yeah, so that's just another name for enterochromaffin cells. So those are neuroendocrine cells that secrete serotonin, and they're going to be found anywhere throughout the gut. And they're important just to be able to recognize because they can look very similar to Paneth cells, but they are normal. And so it's important not to get those confused. We also talked about plasma cells, and so plasma cells in and of themselves are normal in the rectum, but when they're located more towards the base of the crypt, that's when they start to be abnormal and be a sign of chronic colitis. Enterocytes are, of course, just what our normal intestinal epithelial cells are, another name for that. And mucophages are just macrophages that are filled with mucin, and they're also a normal finding in the rectum. Okay, great. So this is a very nice gross specimen demonstrating classical findings of UC. And so with that wrapped up, we'll then put up our second specimen, which will be a nice contrast, I think. Okay, perfect. So just like with our first specimen, as you see it, I'll demonstrate, and maybe people can just comment or shout out what they think, first of all, this specimen is or what surgery has been done here. Okay, so we have small bowel, perfect. Is there anything else? Okay, yeah, cecum, I see, yeah. So this is an ileocolic or ileocecal resection. We have our small bowel running here, and we have our IC valve right there. We have an opening to our cecum, our blinded pouch. And on the flip side, we see a very dilated appendix, sort of sitting in behind here. So that is an IC resection, and what we can see is mostly in the small bowel, we have areas of stricture and thickening of the bowel, basically the entire layers, all three layers of it. And you can see it's quite narrowed in that area. So we sort of have an ileocolic resection, and we seem to have some patchy stricturing or thickening of the small bowel, and the large bowel looks relatively preserved. No mass lesions or anything like that. So does anyone have any thoughts on what the diagnosis may be in this? Okay, perfect. So we have Crohn's disease. Yeah, so that is correct. So as we talked about in a previous gross rounds, there is a differential for strictures in the small bowel, but certainly the most common in this population would be Crohn's disease. And we have a mention of creeping fat as well, which is perfect, is when you get the fat kind of going full 360 degrees circumferential around the entire bowel. So perfect. So this is, yes, by the history, a case of Crohn's disease. And so the approach to grossing a specimen like this is actually quite similar to what we would do with the previous UC case. We again have our systematic approach starting proximally, taking our margin on FAS. We would then proceed to take sections, either one per every 5 centimeters if we think the mucosa is involved, one per every 10 centimeters for mucosa that is uninvolved. And then we would take our distal margin and again look in the fat for any sort of abnormal nodules. And if we don't find any, we would just submit some representative lymph nodes if we can find them. Again, key things to keep in mind with a specimen like this is to pay careful attention to the areas of stricturing, to really carefully section those through thinly to make sure there's no occult carcinomas hiding in there. The other structures here that are a little bit unique that we want to make sure we sample well are the IC valve across the small bowel and the large bowel, as well as our appendix, as we would in the previous specimen as well. And so we're going to submit our sections for microscopic evaluation. Are there any key microscopic features that anyone wants to comment on that could help us distinguish between a case of Crohn's disease like this and UC as we just saw in the previous case? So histologic features of specific to Crohn's disease. Granulomas, perfect. So granuloma is the anglicized version, or granulomata if you want to be ancient Greek. We have fistula as well. So fistula is more of a gross feature, I would say. A fistula is defined as an abnormal connection between two epithelialized surfaces. And so we would see that grossly and then comment on it microscopically. Transmural inflammation, yeah, so that's another good feature. UC, we typically have the inflammation limited to the more superficial layers. In Crohn's, it tends to be transmural. We have crypt abscess. So crypt abscess is sort of a florid collection of neutrophils within a crypt. It is kind of more common to see in Crohn's disease, but it's more of a non-specific feature of inflammation in general. And so it can be seen with UC as well, can be seen in other mimics of those diseases as well. And so granulomas, so that's the major thing that you'll read about in textbooks. Crohn's is granulomas, and granulomas and Crohn's is the subject of our next poll question. So what percentage of Crohn's disease have granulomata? As you can see, I like the ancient Greek version. Okay, so we have almost like a normal distribution here of answers, which is perfect. So yes, so the correct answer in this context is 50%. So if you read the literature, there is a bit of a spread, but it generally tends to fall somewhere in that range, maybe 30% or 20% on the low end, 60, 70% on the higher end. So about 50% is correct. 10% is probably too low, and 75% is probably a bit too high. The key take-home message being here is that if you see granulomas, it definitely helps you to support a diagnosis of Crohn's disease. But if you don't have them, that doesn't mean it's not Crohn's disease, because about half of Crohn's will just not have the granulomas that you see. Furthermore, it's also important to recognize that other conditions can give you granulomas. Does anyone have any thoughts on other conditions that can give you granulomas or granulomata in the colon? Yersinia, perfect. So infectious things can certainly do it. TB, yep, another infection. Sarcoid, perfect. And a crypt rupture granuloma, perfect. So yeah, so certainly there's a differential. So crypt rupture granuloma is really important to remember because that can be seen in the context of UC. So just because you have the granuloma doesn't mean it's Crohn's. It could be UC if it's in association with crypt rupture. TB, Yersinia, other sort of strongyloides, other infections can certainly give you granuloma. And those are very important to recognize because the treatment for Crohn's disease is typically immunosuppression, which obviously you don't want to give if you're dealing with an infection. And so it's important just to keep that in mind. Sarcoid can affect many different organs, and so that's another important differential in any organ to think of when you have granuloma. Foreign bodies can certainly do it. It would be odd to get it within the mucosa, but certainly it can be seen if you have a resection. Interval appendectomy, I suppose, kind of in the same lines. If you've had a prior surgery, potentially in that area as a healing process, you may get some granuloma formation there as well. So good job, everyone. So as you can see, the theme of this morning is sort of looking at IBD and everything you wanted to know and everything you didn't necessarily think you wanted to know about IBD. We had a nice example of UC, and now we have a nice example of Crohn's. And so for our next case poll question, we're going to ask you about some clinical scenarios about what you think the most likely diagnosis might be. And so specifically, we're wondering which of the following scenarios is least likely to be ulcerative colitis. So 25-year-old male patient, sudden onset acute abdominal pain, bloody stools, severe patchy inflammation throughout the colon. Same demographic patient, longer history of abdominal pain and intermittent bloody stools, severe inflammation limited to the sigmoid and the rectum. 15-year-old female patient with abdominal pain, intermittent bloody stools, severe inflammation throughout the colon, as well as some patchy inflammation in the duodenum. 30-year-old female patient with crampy abdominal pain, intermittent bloody stools, and severe inflammation in the sigmoid and rectum, but with some patchy inflammation in the cecum. Or a 75-year-old man with constipation presenting with abdominal pain and severe inflammation of the sigmoid. While you answer that, I will catch my breath. I have to write shorter questions next. Okay, so we have a pretty even spread. So the majority did get the correct answer in this case. So 75-year-old man, history of constipation and inflammation limited to the sigmoid. And so that pattern of inflammation, along with the demographics, as well as that history of constipation that I threw in there, I was hoping to point you towards diverticular disease, which that would be a typical presentation of. And so the other four are all meant to describe various pitfalls in the diagnosis of ulcerative colitis. So in the first case, the important teaching point there is when you have a fulminant colitis, a very severe acute colitis, it can be patchy in UC, and then it over time develops into the more continuous pattern that we typically see. Answer choice B, no one picked because that's the more typical pattern of UC, and we saw that very nicely in the first specimen. C, the important teaching point there is, while the traditional teaching is UC affects only the colon, there is some emerging evidence to say it can have some patchy involvement in the upper tract as well. That's more common in the pediatric population and typically in the context of severe inflammation in the colon. So if you have the duodenal involvement without anything in the colon, that would be more pushing you towards other causes. But a little bit of inflammation in the duodenum with diffuse colonic disease can actually fit with UC. And answer choice D is also kind of an important pitfall, but it looks like no one fell for that. That's just that UC can often be associated with a discontinuous cecal patch. And that's actually a pretty common presentation. So good job on all of you. That was a tough case to answer and tough question to read as well. And so for our next question, obviously, as we alluded to previously, whenever you're grossing a specimen like this, it's critical to look up any potential history of dysplasia on a biopsy, because often, that's one of the major reasons we're examining these specimens, to make sure there is no dysplasia or worse, a carcinoma. And so that's the theme of our next poll question. Which of the following is least likely to be an indication for colectomy in UC? Low-grade dysplasia limited to a single polypoid lesion, low-grade dysplasia in multiple random biopsies, high-grade dysplasia in a single random biopsy, a PT1, so early invasive adenocarcinoma, also known as malignant polyp, or symptoms refractory to medical therapy. Okay, perfect. So the vast majority got the correct answer of low-grade dysplasia limited to a single polypoid lesion. And so the important teaching point here is the most important thing that when we think about dysplasia in the context of IBD is whether or not it's endoscopically resectable. If it's a lesion that can be fully resected and you can go back and prove that it's fully resected by biopsying around the base, that's usually sufficient treatment. But if you have dysplasia in random biopsies, That's more concerning. It could be associated with an occult underlying carcinoma, and that could potentially be an indication for a colectomy. And so that's just, again, important to keep in mind when you're dealing with these biopsies, is the diagnosis of low-grade dysplasia isn't necessarily just benign and just an indication for continued follow-up, because if it's in a random biopsy or particularly multiple biopsies, that can be in and of itself an indication for a colectomy. And yes, if you have UC that's completely refractory to medical therapy, that would also be another indication for a colectomy. We often maybe draw ourselves towards this idea of dysplasia and cancer in UC, and it's important, but we have to remember that the disease itself is actually quite debilitating in some cases and can be life-threatening just from the inflammation associated with it and the hemorrhage. And so if you have severe UC that's refractory to medical therapy, that can be an indication for a colectomy as well. So with that in mind, we'll maybe move to our next question, which is looking at comparing and contrasting these two diseases on a more clinical basis. Which of the following findings are more common in UC than Crohn's disease? P-ANCA positivity, perianal fistulae, fat or vitamin malabsorption, antibodies to Saccharomyces cerevisiae, or recurrence following surgery. Okay, so again, we've got a nice spread between A and D, and so P-ANCA positivity is the correct answer. So that's seen in about 75% of UC, but only about 10% of Crohn's disease. As we talked about, fistulae are more common in Crohn's. Fat and vitamin malabsorption is also more common in Crohn's. The antibodies to Saccharomyces is kind of interesting, and I don't think the mechanism or reason for that is fully understood, but it likely has to just do with the etiology and the interplay between the gut microbiome and the host's immune response. And recurrence following surgery is classically associated with Crohn's disease. UC is treated surgically, and so if you do a colectomy, the patient should technically be cured of their disease, whereas Crohn's does tend to recur following surgery. So that's another important distinction between these two diseases to remember. And if we move to our next question, we kind of get at more of the rare causes of these, but important to keep in mind. And so particularly if you have some of these newer medications used for the treatment of various diseases, we can see a host of medication-associated injuries in the bowel that can mimic UC. And so or Crohn's disease. And so grossly and microscopically, these can actually be indistinguishable. And it goes back to the value of really looking at the clinical history and making sure the patients aren't taking these medications. And so an IBD-like pattern of injury is least likely to be seen in association with which of the following medications? Okay, perfect. So pantoprazole is the correct answer. So these are all important medications that we see with some frequency. And the other important point is we don't always know that the patient's on these medications. And so also that's a PPI. And so that's not classically associated with an IBD-like pattern of injury, but it is associated with a certain pattern of disease in the colon. Does anyone know what that might be? Yeah, perfect. So microscopic colitis. So PPIs in general can be associated with microscopic colitis. But as far as I know, they're not associated with IBD-like patterns of injury. And so I think that's basically everything we have for today. But this is gross rounds, but we don't just deal with pathology, we deal with US history too. And so we have one last poll question. Which of the following 20th century US presidents had Crohn's disease? FDR, Harry S. Truman, Dwight Eisenhower, JFK, or Lyndon B. Johnson? Oh, so we had a dead heat. So the correct answer is Dwight Eisenhower. So he had Crohn's disease. FDR was confined to a wheelchair. It was thought to be polio, but it may have actually been Guillain-Barré syndrome. It's a bit unclear. JFK did have bowel problems, but it's thought to be more IBS rather than IBD. He also had Addison's disease. Lyndon B. Johnson had heart trouble, and Harry S. Truman, as far as I know, did not have any health issues and lived to a ripe old age. The other key teaching point of this question is if you're in a multiple choice situation and you don't know the answer, you should go for C, and you might be right. So I think that's all I have. Have a good weekend, everyone.